Today I have a lot to fit in a short period of time, so I'm going to head right into it. So these are my disclosures. I am going to be talking about some that are relevant. For any companies not on this list, you know where to find me. So, as I was thinking about innovation and how we change the field, I came across this quote. It's such a simple quote, but it really resonated with me. Today, we're going to talk about the status quo. What are we doing right now in the vast majority of places? What's the rationale for transperineal? And of course, we talk about it in a general sense regarding infectious complications and some of the outcomes of transperineal biopsy. So almost 2 million prostate biopsies are performed every year, and that's just in the United States. If we look at Europe as well, we start to see almost 2 million as well. And that's just USA and Europe. And as you can see here, those numbers of prostate biopsy are growing. Despite changes in PSA screening recommendations, shared decision-making, we still are biopsying more and more men. Still, the vast majority of these biopsies are being performed transrectally. And there are about, depending on the series that you look at, about 5 to 7% have some infectious complication. That could be fever, urinary tract infection, epididymolycitis, of course, sepsis, infectious hospitalizations. And it is a very low 30-day mortality, but this is an elective procedure. And when you're doing 4 million of these a year, that means that men are dying of your biopsy. And within 30 days, it's most oftentimes, or there are many that are associated with post-biopsy sepsis. Now, 1 in 4 people who have a biopsy will harbor fluoroquinolone resistance, but this is really what actually drives infectious hospitalizations. Almost 80% of men who are admitted, when we look and we drill down on what is causing that, what is the offending organism, it is really due to fluoroquinolone resistance, and honestly, that's the problem that we have created ourselves as urologists. And these admissions can be very, very costly, up to $20,000 or more, especially if it requires ICU stay with a prolonged period of time. And so what do we currently do? Certainly we want to use antibiograms, looking at our local community and working with our infectious disease doctors. Augmented prophylaxis, which is a fluoroquinolone plus addition of additional medications such as an aminoglycoside. Targeted prophylaxis, meaning we do a swab, but that is extraordinarily cumbersome. You have to do the swab, somebody has to follow up on it, you have to change the antibiotic, counsel the patient, and bring them back for the biopsy after that. Procedurally, we try to decrease the bacterial load by doing enemas. Iodine enemas can help not necessarily sterilize, but clean the rectum a little bit more. Needle disinfection with alcohol or formalin, which is essentially swishing your needle in alcohol or formalin in between each biopsy cord that you sample. And then, of course, transperineal biopsy, which I'll be talking about today. So clearly, rising rates of infections. We've been making the problem worse with growing antibiotic resistance, but now we have the opportunity to completely avoid the rectum with regards to our needle sampling. And what I think, in my personal opinion, it's not necessarily about reducing the overall biopsy infection rate, but rather it is the antibiotic stewardship. And that can be a bit of an obtuse concept to grasp because you're not so personally invested in it as a physician. You're looking for a convenient option to be able to give the patient prophylaxis and move on. But the reality is that our current standards are just creating more and more and more issues. And here I showed, like, for prostate brachytherapy, other percutaneous procedures, they actually don't routinely recommend prophylaxis. So here, the recommendations from the AUA best practice statement have now essentially increased their recommendations. Now they're saying, you know what, we do have a solution. Why don't we add more antibiotics? So now you have to, the best practice, not a guideline, but a best practice statement is saying add an aminoglycoside, typically intramuscular, and oftentimes it's going to be underdosed because you can't give single weight-based dosing with that much volume into a muscle, which is inconvenient for your practice and it's painful for the patient. So we have we never thought we could do this before. We were doing grid, saturation sampling, doing it under anesthesia, but we have new periprostatic blocks where we understand that we can deliver effective anesthesia during the procedure, so you don't need that stepper or a grid. novel sampling strategies and techniques, and really we don't add morbidity to the procedure, and of course the antibiotic stewardship that I mentioned previously. Now, one of the big concerns I hear from new people entering or thinking about performing a transperineal biopsy is the concern about the patient's experience with pain. And so I just wanted to spend a couple of minutes just talking about this because it's very important. There are lots of different strategies. There is mixed data on being able to buffer or alkalinize local anesthetic, which is acidic and can sting, that gives that burning sensation when it's injected. But I think the most important thing is putting it where it needs to go and using just the right amount. So when we first started, we were putting 30, 40 cc's of half or 1% lidocaine into the, or local anesthetic into the perineum because we didn't know exactly where to go. We're just trying to hope it diffuses everywhere and hope my needle goes through that path. What we've learned is that we can I typically will give about 15 cc's of local total during a procedure now. Helps limit also vasovagal events that can happen. Ethyl chloride, that's right here. That's the, ooh, let me go back here. The ethyl chloride spray right here, this is actually over the counter. It's used a lot for venipuncture. You spray it until the skin turns white. If it has this extreme cold sensation, and it's numb for about 5 seconds. Now, it's less about the pain, but it's more of a distraction technique. It's much easier for a man in lithotomy to process a cold sensation than what they know is a needle coming to their perineum. And we can use simple things that our anesthesia colleagues do. Prior to surgery, they pre-medicate with Tylenol. And there are, of course, you can do it under sedation. MKO melts, which is something a colleague of mine, Dr. Fry, actually introduced me to. It is midazolam, ketamine, and ondansetron. It is essentially conscious sedation. It's regulated substances, so it does require a little bit high level of care. Of course, there's IV sedation, Valium. And nitrous oxide is a great option. So this system that you see down here in the bottom left, that's Pronox. It's 50% oxygen, 50% nitrous oxide. You cannot control the amount or the concentration of nitrous. There's virtually a 20-minute in-service that you and your staff have to receive. It's essentially patient-controlled analgesia, so they have a mouth inhalation piece, so they can't overdose themselves. They can just be monitored for about 5 minutes, and they can drive themselves home after the procedure. Really, really good option. Now, how do I do the procedure? This was my setup in my actual office in Michigan. Patient is in lithotomy. We use yellow fins because it takes the weight off of their heels, but you can use gynae stirrups or anything else that you have in your office. We do clip or trim the perineal hair. And then we do perform a skin prep with chlorhexidine, iodine, whatever you have convenient to you. So these are the different permutations that you can put together to be able to, you need to really pick one from each of these categories to be able to perform your transperineal biopsy. In my mind, I prefer the long linear crystals. There's essentially a brachy probe, but your conventional transrectal probe you can do it that way. When you're starting off, it is a little bit more challenging. Your view within your window is much shorter, and because it's a convex sagittal crystal, your needle appears like it's coming from the bottom right of the screen going to the top left. I personally use yellow fins, and of course, there are different access devices. So how many needle guides do people think exist for transperineal biopsy? Anybody shout out a number? 7. There are many, many transperineal needle guides out there. Okay, so when I was starting to look and understand what is out there on the market, there are many, but many people just don't know about them. So some of them may be familiar to you. There are going to be some exhibiting here. There are both non-disposable and disposable needle guides that can be used to fit what works for your practice and your probe. A lot of these are also specific to the ultrasound vendor that you have. I'm not going to go too much through the fusion technologies because Dr. Pinto did already, but there's different ways in which you can perform fusion, and most all of these now offer a transperineal approach, where that may not have been the case 2 or even 3 years ago. 3 or even 2 years ago. So you have electromagnetic tracking, angle-encoded sensors, the 3D ultrasound, and also software-based fusion. So do you always need to give antibiotics during a transperineal biopsy? This was the NORAP trial, which basically took two groups of men with transperineal with antibiotics versus transperineal without antibiotics. Now, my criticism of this trial was that the non-inferiority margin was 4%, which is quite high. But regardless, it did show us that, so antibiotics were either cefuroxime or without antibiotics. They were all performed as fusion biopsies, and they did exclude these patients who are a much higher risk of infection. Now, that most transperineal populations are actually enriched by those who have like immunocompromised or diabetes or recurrent urinary tract infections. Now, the primary outcome here was infectious hospitalization within 60 days. Now, I just want you to focus on the lower thing if you can see it. It's basically there was zero sepsis in both groups, very few UTIs in both groups, and essentially it was determined to be safe to be able to perform a transperineal biopsy without antibiotic prophylaxis. That is the standard that we use at Johns Hopkins now, and that is the standard that this trial helped change when we started doing it just immediately prior to leaving Michigan. Complications of transperineal biopsy. In general, based on the studies, no difference in biopsy-related complications, no difference in hematuria, no difference in urinary retention. These are all concerns that I've heard before, and very, very few men have hematochezia or blood per rectum, as there's no needles going through the rectum. Now, what is the level of evidence in terms of cancer detection? Some of us love to say that transperineal detects more cancers. I don't necessarily believe that that is true. I think there may be specific instances where one technique may be better than the other, but I believe that they're generally the same. Just to summarize this, no difference, no difference, no difference. And these are randomized trials that were done as early as 2008. So it's really important to know that while we think that we're innovating the field, it's just the recent adoption here. So if we look at observational cohorts, similarly, we see higher rates of cancer detection, if you can see here. And then also a study from Canada, which also shows us almost a 50% of overall cancer detection rate with the transperineal biopsy. Now, there are many, many series that have been published in the literature now. I've selected out some of the larger series that I think would be relevant to the audience. The EAU guidelines have reviewed this, and they've said essentially when you're taking the same number of biopsies, your approach doesn't really matter. Your cancer detection rate is going to be the same. How about the patient experience? Again, no difference in biopsy-related complications. Here, the visual analog pain score, as many of you know, the Wong-Baker FACES pain scale, there was a difference in the GWO study, which was 4 versus 2, so slightly more painful with the transperineal biopsy. Interestingly, this Italian study showed no difference between the two, but what was interesting about it is that they just put 3 cc's of local anesthetic at the apex. I've tried that. That did not work for me, but I welcome all of you to try it to see if that works. Another question that I commonly get is, well, from the saturation biopsies, the risk of erectile dysfunction and urinary symptoms. Here, I just want you to focus on that there is really no difference across different time points with a transperineal biopsy at all. So really, your functional outcomes stay exactly the same. So our experience in Michigan, this is unpublished data, what we see is that we do see a slight increase in pain with a transperineal biopsy. Now, that makes sense to me because the area is sensate rather than above the dentate line. But when we dig down a little deeper, this is all driven by the local anesthetic administration, which is about that 30 seconds that you're giving it. And after that, when you're actually doing the sampling, they're actually very, very similar. Now, some have reported that minimum clinically important difference for the pain scale should be 2 points, and we're certainly, we don't reach that. We don't even reach 1 point here overall. So what are the pros of transperineal biopsy? I think we mentioned before the reduced risk of complications, and improves stewardship, improves your workflow. For those of you who are already familiar with rectal spaces and employing it in your practice, very similar approach, similar cancer detection rates. Still, people question the patient experience, and it does take a little bit longer, especially when you're getting started. The learning curve is shorter than you would think, say approximately about 10 biopsies or so. And then cost and reimbursement regarding capital investment is, of course, a concern. We do have a number of resources that have been provided by the Michigan Urologic Surgery Improvement Collaborative. If you scan this QR code, you're going to see what's available to you. One of those is a checklist. So there are all these pieces that you need to be able to perform the biopsy. What this does, it makes it very easy for your office staff, manager, goes there, it tells you what is the manufacturer, what is the item number, and then you can just go straight to it and order it. Similarly, we have a template that's been utilized within music. It is a 12-core template that has been modeled off of the modified 12-core Barzell template. And this can actually be printed as a PDF. What I do is I have laminated it, and on the other side it has the names of the locations in a grid. We put our biopsy pads there. We put the cores in the pads. We wipe it clean, and we use it for the next biopsy. We also have a number of training videos on the music website. How to perform the local anesthetic block, which I think is the most important part of the entire procedure. Video of the standard technique to perform just a systematic biopsy. And this is a great resource. It's a patient educational video. It's not branded by an institution or anything like that, but rather it gives you a short 5-minute video that you can present to the patient that we use for biopsy teaching, or even prior to the consent, and then you can come in and ask if they have any questions. It's freely available. I use it routinely in my practice, and a lot of people, in terms of being able to describe eloquently what the differences are and what the potential benefits are, you can just play them this video on an iPad or something else, and move forward with your procedure. So I'd like to thank you for your attention.